Good afternoon, everybody. Thank you so much for joining us today. My name is Marie Stuckey. I'm the Member Relations Manager at the Maine Health Management Coalition. And today we are pleased to present you with some education on navigating the operational and legal logistics of telemedicine in Maine. We're grateful for our presenters today, and I will be introducing them shortly. But I just want to cover a little business first. So I will go through a little information about the coalition for listeners who are not aware of the work that we do. And for listeners who are members, we have a little information on some upcoming events. Before I get into that, I just want to quickly let you know that this presentation and slides will be archived on our member website. If you have a question at any time, feel free to type it in the chat box, and we will do a question and answer period at the end of the presenter's time, and I will relay those questions to them for you. Also, you may notice that there are some handouts attached to this webinar that the presenters have provided, and they can speak to them as we get further into their presentation. So let me just start by letting you know that the Maine Health Management Coalition is a purchaser-led partnership among multiple stakeholders. We all work together collaboratively to improve the health and maximize the value of healthcare services for the employees and dependents of our members and for all the residents of Maine. We currently have over 80 members, and they're comprised of the five different member categories that you see there, but again, we are member-led. We achieve our goal to improve the value of health care in Maine through the five initiatives on your screen. So our data department is really the foundation for that improvement, because we have all the health benefit claims for the entire state. So we do benchmarking and practice reports. Employers are able to kind of assess their plan performance through some of the data analysis our data team provides. We have a public website for reporting on the quality and cost of care, where we provide information on outcomes, safety, patient experience, and cost. That's called Get Better Maine. We also work with our members to help them to communicate information about the best wellness and health that people can take on themselves to promote their own health. So that's our member and consumer engagement. We work on benefit design to provide and work with all the major health plans in the state to develop and promote plans that reward the use of high-quality, patient-centered care at reasonable cost. And that leads us to payment reform, where we work with hospitals, systems, and providers to look at different payment arrangements. So moving on, we just want to mention some of the great benefits of membership here at the Coalition. All our members love to network with each other. They have great opportunities to do so in some of our events. They learn a lot about best practices in health plan design, as I alluded to before with the data work that we do. They have access to train their leadership and staff through educational events and resources, and are guided to high-quality, reasonably priced healthcare services. They're branded as a health pioneer in the state, which is seeming to be increasingly more important lately as people are having difficulty recruiting good talent to the state. We have a lot of work groups that we offer that people can take part of, and I'll talk about that in the next slide a little bit. And of course, webinars such as this are another benefit for membership, because they're free for members. Our members have voting rights for key elections, so they have a voice at the table. And then we also offer some discounts on different conferences and services for our members. So moving on about the meetings. In this month, there are 3 meetings coming up that where our work groups work on the background scene of how we will publicly report on that Get Better Maine website. And those are the PTE meetings you see on your screen. So if you have any interest at all, please reach out to get a little bit more information and join us. Finally, you'll see on April 28th, we have a member-only, all-member meeting at the Daniel Hotel in Brunswick. This is going to be a really exciting event because we are going to have a keynote, a discussion of data trends, and a panel discussion, all on specialty pharma spend. So that should be a great meeting, and we hope all our members will join us with as many people from their organization as they want to bring. Here again, just be aware of the work groups and committees you can join as a member. The voting rights, some of this I've already mentioned. Our symposium dates already selected for October, so save October 27th on your calendar. Members get a complimentary registration to that event. We also have a member newsletter and some pilot programs that are available just for members. I think I mentioned everything else, so we'll move on. If you'd like to register for some upcoming webcasts, later this month we'll have Lori Parham, the Executive Director of AARP, talking about the topic I just mentioned, recruiting and retaining good talent, but through Maine's aging workforce. And then in May, we have improving population health outcomes through better nutrition with a case study from the Jackson Labs. And then finally, at the end of May, the financial and legal guidelines of a successful wellness program. And that one I think is going to be particularly interesting. Please note that the May 25th and April 27th webinars are approved for HR credit. Here's a slide just showing the logos of some of our great members. And with that, I'm excited to introduce our two speakers today. First up, we have Dr. Michelle Lauria. She is the Chief Medical Information Officer at Eastern Maine Healthcare Systems. And in that role, she leads the design, implementation, and support for healthcare informatics and clinical information systems across EMHS. Dr. Lauria became the first Chief Medical Information Officer in 2015, and her job is to work closely with clinical and business disciplines to embed informatics and analytics into care processes and clinical service planning. So this involves making sure information systems are well designed, easy to use, and they provide the right information at the right time so patient care can be delivered both effectively and efficiently while continuously identifying ways to improve outcomes. So prior to EMHS, Dr. Lauria was the Associate Medical Director for Information Services at Dartmouth-Hitchcock Medical Center in Lebanon, New Hampshire, and Professor of Obstetrics and Gynecology and Radiology. She's board certified in clinical informatics, maternal fetal medicine, obstetrics, and gynecology. Dr. Lauria enjoys teaching and working collaboratively with teams to solve problems and find opportunities to continuously improve healthcare delivery. And we thank her for joining us today. And David Schneider, an associate attorney at Bernstein Shore, will follow her presentation. Since earning his JD with highest honors from the George Washington University Law School, Dave has provided counsel to a variety of corporate clients, including numerous Fortune 500 companies. He specializes in a wide range of corporate matters, including mergers and acquisitions, debt and equity financing, and structuring effective executive compensation plans, among many others. Dave provides counsel for business, corporate governance, healthcare, intellectual property, and mergers and acquisition industries at Bernstein Shore. Prior to his role at Bernstein Shore, Dave was a business associate at Batchelder and Dowling, and also practiced at Simpson Thacher and Bartlett's New York office with a focus on executive compensation, mergers and acquisitions, and capital markets. Dave serves on the South Portland Economic Development Committee, which works to promote and strengthen the local economy, and in his spare time, he enjoys long-distance running and traveling. So we are very grateful for them to share their expertise with you today. With that, we're going to pass controls over to Dr. Lauria, who will begin our presentation. I'll just take a minute for her to get those controls, and you'll see her slides come up on the screen.
Hi all. Can you see my slides?
We see them just fine. Thanks so much.
Excellent. Well, it's a pleasure to be here today giving this presentation, and I really want to thank the organizers and Marie for doing such a great job of coordinating this and helping us improve our presentations and making sure this happens. I think it's a really important topic, e-health and telemedicine. And I'm going to mostly be talking about the operational considerations. I'm going to start with an overview of the larger topic of e-health, and people sometimes call it telehealth. There's all sorts of different catchphrases that are out there now. And then dive down into types of telemedicine, and then really focus on the interaction of people, process, technology, and culture. And then give some examples of successes that we've had here at EMHS, and then some of the factors that we think were important in our stumbles. So e-health in general is the provision of health care when the participants are separated by distance and or time. And it's really the use of technology to permit that provision of health care. And some people say, well, why do e-health? Why do you want to put technology in there? And to me, it's because it allows us to address the 3 R's plus 1. The right care, meaning that you can provide more immediate access to specialty services, or maybe you can get a PCP involved in a process that might be difficult to involve them in should you not be using technology. It means providing care in the right place. So not only is it the right care, but it's in the right place, reducing travel times, and with the right person. You know, can you get greater continuity when you're using technology to help provide healthcare? And then finally, giving the right experience. And I think that's a key part, because e-health or telemedicine is not right for every experience, not every clinical situation, but it can be used to give the right experience, not only for the patient, but also for the provider. And we'll get into some of those considerations as well. So what's the scope? Well, it includes text-based communication, so the ability to text back and forth with clinicians, with office nurses. I know I did a lot of diabetes care, and really the best way for us to get blood sugars was for somebody to text them to us, because then we had them, we could put them in the record. You didn't have to worry about getting someone on the phone. Using patient portals, that's another part of e-health. You know, patients can do self-scheduling in the middle of the night when they have time to think about it rather than during the workday. Other types of text-based communications can be communications between providers. Think about store and forward image review, EKG analysis. When you're confused about a radiology image, you want to be able to review that image with somebody who's not sitting right next to you. Another component is the use of telephones that we document in the EMR. And then finally, telemedicine, which is what we're going to be focused at today, which is a real-time audio-visual exchange between patients and providers. When you think about telemedicine and that real-time video display, you can have scheduled telemedicine, such as consults and follow-up visits, and you can have on-demand televideo. I'm going to include in this some store and forward techniques just to think about e-visits and imaging. Some folks will include remote monitoring in telemedicine and care management in telemedicine. This is what the EMHS telemedicine telehealth services currently looks like. EMMC is a provider of telemedicine services to a variety of hospitals that are both in-network and out-of-network. Excuse me for 1 minute. I'm going to close my office door. I didn't realize I left it open. Through EMMC and then through our Acadia Psychiatric Hospital, we also provide telemedicine services to a variety of different hospitals in their ED departments. Anytime you talk about change these days, though, you have to think about the pyramid of change, and the The technology of telemedicine can be really sexy and get really involved in the iPads and the different devices and the really cool robots and everything that are used, and concepts like telesurgery and robotic surgery with somebody many, many hundreds of miles away. But you'll notice that technology is really just the tip. And in order for it to be successful, you have to think about the whole pyramid, the culture, the people, the process, and the technology is just a small part. So there can be a lot of barriers to telemedicine. When you think about technological barriers, broadband, Maine's a really rural state. I came here from New Hampshire. New Hampshire and Vermont, not only are they rural, but we've got granite in New Hampshire and a lot of trees in Vermont. Means that you don't get good cell phone signals. It's rural. You often don't have good broadband. There's also security issues when you think about the platforms in which you set up your telemedicine. Most of us are using Skype for Business or GoToMeeting or items like that, but what about the potential for HIPAA violations if you're using the same application for both your business scheduling and for patient scheduling? There's lots of process issues to consider. Licensure and credentials, licensing within a state, and Maine is reviewing legislation right now. Also documentation, whose record do you document in? And billing. People is a real barrier. Everybody already has a really full day job when you're trying to set up a telemedicine program. So, that can also be a barrier. And culture. A lot of physicians are in the 50s and 60s. The thought of doing something via video and audio can be quite daunting, and it can be quite daunting to our patients as well. I think our younger generations are very comfortable doing things with audio-video feeds, and they see the benefit, but they don't consume the majority of healthcare. Also, how do you define the return on investment? People all want to see the hard dollars and cents, but the fact is, as an organization, if someone's driving to you and they're there in person, you're going to use much less technology. They're sitting there in your waiting room. That may be much more cost-effective than setting up complicated audio-video systems to see them in another setting. So the return on investment really needs to have a broader scope than what we typically think about, and it's about a lot of the 3 R's plus 1 that I discussed before, keeping providers from having to drive as often to outreach clinics, patient continuity, satisfying your patient base, meeting the patient's needs where they're at, defining and maintaining referral arrangements. Those are a little more difficult to identify a return on investment, and often you can't put dollars and cents, but often they're what matters to patients and to clinicians, being able to maintain that continuity of care and that ease of care. So thinking about technology and process. To have a successful program, your technology has to be rock solid. It has to function as easily as a telephone. Once your video feed doesn't work and someone just picks up the phone and does it via the telephone, you're not going to meet the billing requirements for the telemedicine visit. But also the telephone's so much easier if your video isn't working. The providers are unlikely to go back. And when that happens, what you really need to do is an immediate debriefing the next day to say, why didn't our video feed work? What can we learn from this? How are we going to fix it? First of all, that allows you to identify the problems immediately, but it also shows to the clinical area that you are deeply committed to making this telemedicine technology work for them. And therefore, they're going to be more likely to try it for the next visit. Also, image transfer functionality. If you look at cardiology images, echoes, MRIs, they have really high bandwidth requirements. How do you transfer those images? How are they going to be stored in the EMR in which they're being read? How do you transmit those reads back? How are they incorporated perhaps into the local EMR? That requires a lot of work. There's also the process issues of governance. It's a new way of providing medicine. Most of us weren't trained in how to do telemedicine during our residency programs. This is something that we're creating. How do you govern equipment, where equipment goes? How do you govern what patients are appropriate for telemedicine visits? How those interactions occur? Thinking about how and where to document. Which EMR do you use? What are those rules around that? Billing with a modifier. Also, if you need to show a return on investment, defining that return on investment up front and identifying your key performance indicators before you start a program, and then tracking those key performance indicators is really important if you're going to be refining your process to be continuously improving, and defining best practice. Best practice can occur in a lot of different locations, and if you don't have any measures, you're not going to be able to identify it. Program staffing. It can be really big or it can be small. Sometimes people can add this on into their current work functions, although that can be difficult to do. Ideally, you would have an administrative director who's going to be coordinating all of the various telemedicine initiatives within your organization. They'll be leading a working group, and they'll be figuring out how all of those different requirements for telemedicine operationally fit within your organization. It helps to have a medical director or champion, somebody who's really got their hand into what's being offered by other organizations, where are their successes, what's working well. They can help develop telemedicine workflows, identify best practice, look at new areas to expand in. They're often the person that can speak really eloquently. Sometimes these folks are big innovators. Sometimes it's good to have an early adopter in that role, because your innovation can sometimes not always work, and again, back to that fact that you need that rock solid technology. Nurse coordinators are really important. Training staff at spoke sites on the technology. They can assist with intake and triage, making sure that you've got the right processes in place to decide which patients are appropriate for telemedicine visits. And they can be dedicated or shared part-time with the service line. The technology part does require somebody with IT expertise dedicated to telemedicine. When things break, they need to be fixed quickly, and they often require a different type of expertise than a large bank of health staff individuals. Also, you want someone who can support the innovation, who can think about the hardware requirements as you think about new areas or new processes to which you want to apply technology. And then IT staff, who's going to be working on just that day-to-day functioning. People, if you remember, now we're getting really close to the bottom of that pyramid. Governance applies to people as well. They're going to want to know the rules, the new rules for how we behave in this new setting, what we have to do. A telemedicine visit often requires more assistance and not less assistance at the site where the patient is. They're going to come in and they're going to register just as they usually do, but rooming the patient in vitals, that has to be done at the remote site. It has to be done by support staff. Patients aren't going to room themselves and do their own vitals. So you have to think about this when you're trying to set up a location. Again, where does documentation occur? What device is going to be used to see that patient? How are they going to be positioned so that the consulting provider can see them? If they're elderly, they may need assistance in the room. Providers often in the room with the patient are doing a lot of things to assist that patient. They're helping the patient move around, get on a table, maybe helping move parts of the garment. You're going to need somebody in the room to do those activities. And so often you may need to have a dedicated medical assistant in the room helping that remote provider perform their evaluation or making sure that the technology is continuing to work. And then really sometimes the most complicated issue is culture. I think I've already addressed, some of the non-traditional returns on investment. Reducing provider travel opens up more clinic time. It can generate more revenue within system tests, but we're not typically used to doing our ROIs looking at that. On the site that's providing the telemedicine, so if I'm a cardiologist seeing patients remotely, it does free up some office space on my side, and that can be really useful, but I'm not going to be reimbursed for the facility charge. So do I really want empty clinic rooms sitting there? Or are we going to put someone else in those clinic rooms during my office visits because we're now foregoing those facility fees? How do you validate that you're generating more revenue within system tests? It's another good question. And again, while it provides you with a broader geographic scope for your patient base, it does require more technology. And again, getting over that technology barrier with your providers who are going to have very little tolerance for technology not working. So some successes. EMHS through Valerie O'Hara has a great program called Way to Optimal Weight. And what they do is they provide multidisciplinary visits via WebEx. They give a one-way invitation from the provider's office to the patient. So they send the invitation out to the patient accepts that WebEx invitation. And the patient sits in a virtual, in their virtual location in another remote hospital. And then various people take turns on that same WebEx seeing the patient. This has been a real good success because their lead physician is one of those early majority folks. Not really a super geeky innovator with technology, but early majority, so very pragmatic approach to technology and workflow, and they've been highly successful. And have been able to provide services to patients that they otherwise would not be able to meet and serve. Another success at EMHS is the PICU, and they do on-demand consultations to providers. This has been a very successful program because all of the providers are really dedicated to providing the service. They have very consistent service quality among that group of providers. They do video conferencing to see the patient and telephony. So they're able to provide critical advice to providers and emergency departments and help them better define when the patient needs to be transported for a higher level of care. What are some of our stumbles? We've had some stumbles due to lack of clear leadership. Innovators are often not good leaders because they really like the technology. They can be distracted at times by the next exciting thing to do. And often they're not really good at understanding the cultural and process adaptations that need to be had. We've also had some stumbles with service and consistency. Referring providers want a really consistent service, so it's really important that everyone within that telemedicine program have a similar level of deep commitment to the program. We've had some problems with inconsistent technology and realized that, as soon as your televideo isn't working and someone picks up the phone, it's just so much easier, and the telephone always works. And then some of the problems we've had are with billable models. Consultants with critical care specialists, those consults aren't billable if the patient's admitted the same day. So, you can spend 3 hours on the phone with somebody trying to decide whether or not that patient needs to come, doing that consult, and then if they do come, you can't bill all of that consultative work, and it makes it a model that you can't maintain. And I think really it speaks to the fact that every great tech person needs translation, and you can see that even R2-D2 had his great translator. And I think there's some really great novel ideas that I can come up with about how we can improve the overall quality of care. We know that the transition from hospital to home and from the hospitalist specialist care back to the PCP can be really complicated. Well, wouldn't it be great if that PCP could join that final discharge planning day for 10-15 minutes so they can see what the patient looks like before they're discharged home, so they can ask questions in front of the hospitalist or the specialist that have been caring for the patient during that admission. This could reduce admission rates. It's not reimbursable for the PCP, but it may improve, their job satisfaction, the quality of care they provide, and overall benefit patients and healthcare systems. I also have heard of a lot of stories where nurses doing televideo visits, it gives them a window into the home environment. They can get a better sense of what the patient is struggling with and what may be a barrier to the patient being able to follow through with the recommendations of the provider, and may help the providers or clinicians better refine those recommendations, come up with solutions that work for the patient in their home environment. And that's all I have to say.
Thank you so very much. That was great information. And again, I want to remind people that you can enter questions into the chat box and we will relay them after the next presenter. So I will be giving some controls over to Dave Schneider, who will now talk about the legal aspects of setting up telemedicine in Maine. Dave?
All right. Thanks, Marie, and thanks, Dr. Loria. That was a great presentation. Just to recap the presentation today, Dr. Loria was covering the operational aspects of telemedicine in Maine, and I'll be covering some of the legal aspects of telemedicine. And one thing that Dr. Loria mentioned is that there are many definitions of telemedicine floating around there. First of all, I think that telemedicine is a little bit of a misnomer. I think it's better to be called e-medicine because it doesn't really involve the telephone anymore. It's involving interactive audio, video, and other electronic media. And when I'm looking at this issue as a lawyer, I'm more concerned about what the law defines telemedicine as. And Maine law actually does have a definition for telemedicine. Under Maine law, telemedicine is defined as the use of interactive audio, video, or other electronic media for the purpose of diagnosis, consultation, or treatment. Under Maine law, it specifically excludes the use of audio-only telephone, fax machine, or email. So video conferencing services like Skype or GoToWebinar, like we're using now, or Citrix, those are okay vendors to use for telemedicine, but services like the telephone or email are not. And I guess there are still some questions around whether other interactive media is going to be permissible for telemedicine, such as social media tools like Facebook or Twitter or other interactive chat mechanisms. So there's four main issues that I'm going to be talking about today. The first is one that's always at the forefront of the provider's mind, is how are they going to get paid for these telemedicine services? The second of all is how can they provide these telemedicine services while complying with the regulatory or licensing regime of the state of Maine. Third, and Dr. Loria did touch upon this a little bit, is that when you're using telemedicine, there's a heightened sense of patient security that that providers are going to have to be aware of. So there's federal and state patient privacy laws, including HIPAA, that they'll have to address. And the fourth and final issue that I'm going to talk about today is the corporate practice of medicine. So first, I'm going to talk about the payment for telemedicine services. And there are three main payers that I'm going to talk about. The first payer is private health plans, such as Aetna. The second main payer is Medicare, and the third main payer is MaineCare, or Maine's version of Medicaid. So first, this first slide that I have up right now is for private health plans. And Maine law actually has a law that says that private health plans must cover telemedicine services as if the healthcare service had been covered for an in-person consultation. So if a plan covers an in-person consultation and you can provide the same service through a telemedicine service, that private health plan has to cover that service. Maine law actually goes a little farther than other states in the region, where they say that the deductible copayment or coinsurance for a telemedicine service cannot exceed the deductible copayment or coinsurance for the same service if it were in person. So that means if you have a $20 copay for an in-office visit, the deductible or the copay for a telemedicine visit cannot exceed that $20. The second payer that I'm going to talk about is Medicare, which a large percentage of the payments in the state of Maine is going to be through Medicare. In general, Medicare is much more limited and restricted than the other payers in the state of Maine. The current rule under Medicare is that reimbursement for telemedicine services will be permitted only if the following two requirements are satisfied. First, the telemedicine service must be eligible for reimbursement. So there are only specific codes that are eligible for reimbursement through telemedicine services. So services like psychotherapy, smoking cessation, obesity are eligible for reimbursement. And even though the list is pretty limited right now, I would note that the list of eligible services keeps getting longer and longer every year. They keep adding additional codes to that list of eligible services. The second requirement is that the location where the patient receives services cannot be in a metropolitan statistical area or is in a rural census tract or a health professional shortage area. The location where the patient receives the service must be in a physician's office, hospital, clinic, or community health center, and cannot be in a patient's home. If the reimbursement is approved by Medicare, the site where the patient is located is typically paid a facility fee, and the distant provider where the physician is located is typically provided the Medicare rate for that service. So you'll see below I have two postcards from within the state of Maine. The one on the left is a postcard for Millinocket, Maine, and the postcard on the right is for Bangor, Maine. Let's assume that a patient goes in for a service that is eligible for reimbursement through telemedicine. If that patient is located in Millinocket on the left, that service would be eligible for reimbursement because Millinocket is in a rural area. On the other hand, if that patient was located in Bangor, Maine, that service would not be eligible for reimbursement because Bangor is a metropolitan statistical area. The third and final payer that I'm going to talk about today is through MaineCare, or Maine's version of Medicaid. The current rule is quite limited and narrow. Reimbursement for telemedicine services is permitted only if it is medically appropriate, that there's a travel or distance issues that make delivering the service in person difficult, and the provider has had prior approval from DHHS. So all three of those requirements must be satisfied in order to be eligible for reimbursement under MaineCare. So in practice, with all the administrative burdens placed upon providers to prove that there's a hardship and to gain prior approval from DHHS, what we found is that there's a very low participation rate right now for telemedicine services that are reimbursed by MaineCare. But I do want to talk about an exciting new proposed rule under MaineCare that I think that providers who may have looked at telemedicine previously and may have discarded it or determined that it wasn't going to reimburse them for a lot of the services or it was too burdensome. There's a new proposed rule under MaineCare that may cause physicians and providers to take a second look at providing telemedicine services. The new proposed rule, which has not been officially finalized yet, is that reimbursement for telemedicine services will be permitted as long as it's medically appropriate, period. So what MaineCare and DHHS has done is that they eliminated the prior approval requirement, and they also eliminated the distance or hardship requirement. In addition, there's some added flexibility because unlike in Medicare, the site where the patient is located can be in the patient's home. One of the only restrictions for telemedicine is that it must be interactive and in real time. But there's even an exception that if an interactive service is not available, the telephone could be permitted. Much like Medicare, the originating site is paid a facility fee, and the distance per site provider or physician is paid the main care rate. There's also an additional new service that's discussed in the proposed rules, and that's telemonitoring. And the best way that I can describe telemonitoring is similar to the wearables, such as Fitbits or Jawbones that people are wearing these days. What the new telemonitoring service does is provide reimbursement to home health agencies to monitor patients. So some of the types of services that home health agencies might want to monitor on a patient is pulse or blood pressure. And if that home health agency or a nurse or physician receives an alert that the pulse has dipped or blood pressure is low, then they can intervene with that patient and find out what's going on with that patient. So that's another new exciting development within the new proposed rules that home health agencies may be interested at taking a look at. The second issue that I'm going to talk today is the licensing regimes for Maine physicians under the Maine Board of Licensure in Medicine. So with respect to physicians who are licensed to practice in Maine, there's a specific law in the books that say that a physician licensed to practice medicine in Maine may practice medicine through telemedicine. So if you're licensed in Maine, you're allowed to use telemedicine. One thing that physicians must keep in mind is that they still have a standard of care to uphold, and that there may be some services in which they are not appropriate for telemedicine. Using a video conferencing services, you might have audio and video, but there's other senses that might not be available to that physician, such as touch or smell. So, for example, an annual physical may not be appropriate for telemedicine because that physician wouldn't be able to touch the patient. The Maine Board of Licensure in Medicine has issued guidelines, so I would also suggest that any physicians or practitioners take a look at those guidelines. I also want to talk about physicians who are from away, or physicians who are not licensed to practice medicine in Maine. And this is a specific law that's been recently passed in Maine, and I like to call this law the Mass General Law because several hospitals and other clinics throughout Maine use Mass General's telestroke clinic, but a lot of those doctors located in Mass General, because it's in Massachusetts, aren't licensed to practice in Maine. But in the case of a time-sensitive stroke or potential stroke victim, they need to be able to talk to a specialist or a neurologist immediately. So Mass General or other hospitals located outside Maine might be able to provide those services to those hospitals. So there's a specific law that allows a physician not licensed to practice medicine in Maine to provide consultative services through interstate telemedicine to a patient located in Maine, as long as that physician is registered by the Board of Licensure, but it doesn't have to be licensed with the Maine Board. There's a couple additional restrictions that I should discuss. The physician may not open an office in Maine, meet with patients in Maine, receive calls from patients while that doctor is in Maine, and the physician must agree to provide only consultative services as requested by a physician licensed in Maine, and the physician licensed in Maine retains ultimate authority over the diagnosis, care, and treatment of the patient. So again, this is similar to the telestroke clinic located at Mass General, in which a doctor located in a Maine hospital can reach out to a specialist around the clock located in another state and get advice and consultation from that doctor or specialist. The previous two slides I was discussing physicians, and I also wanted to touch upon psychologists because telepsychiatry and telepsychology is a growing field that people have interest in. And the same in-state rule applies to psychologists. So an individual licensed to practice psychology in Maine may provide telemedicine services in Maine. But unlike the Mass General rule that I previously discussed, a individual who's not licensed to practice psychology in Maine may not provide telemedicine services to patients located in Maine. So that's a little different between physicians and psychologists. The third issue that I'm going to talk about that Dr. Loria discussed upon is federal patient privacy laws, including HIPAA. In general, HIPAA imposes certain privacy and security requirements on covered entities with respect to protected health information. So the first question you might want to ask yourself is the distant site provider where the physician is located a covered entity? And the answer is going to probably be yes, unless that provider does not engage in certain electronic transactions such as submitting claims electronically or determining eligibility electronically. That physician is going to be a covered entity, and most likely if that physician is tech savvy enough to be using a telemedicine service, that physician is also going to be tech savvy enough to be submitting claims electronically as well. So my advice to physicians who are using telemedicine is to be aware of the increased risk to the security of their system. So they might want to take additional enhanced measures such as encrypting technology and authenticating that a link between the provider and the patient is not being hacked and remains secure. In addition, the same privacy rules that apply to a physical office also applies to that physician who is providing it over a telemedicine service. So similar to a physical office, the physician must provide a notice of privacy practices to the patient. The physician or practice must also adopt HIPAA policies and procedures and do an annual risk assessment, which would probably take into account the fact that there are services being provided over a telemedicine video conferencing service, and that additional safety measures should be taken. And in general, that provider is going to have to comply with the same HIPAA privacy rule and security rules that physical or office-based doctors provide. A common question that physicians ask is whether the video conferencing vendor that they're using is a business associate. There are many video conferencing vendors out there, such as Skype, Skype for Business. Right now we're using GoToWebinar, so that's a similar service. And physicians want to know whether the video conferencing vendor is a business associate and whether they're going to need a business associate agreement with that video conferencing vendor. My response is always that it's unclear until there's further guidance provided. Under HIPAA, a business associate is defined as a person or entity who creates, receives, maintains, or transmits protected health information. So clearly, a video conferencing vendor is transmitting protected health information between the provider and the patient. However, the final regulations provide that those who do not access the information other than on a random or infrequent basis are not business associates. So therefore, it's a little unclear whether you need a business associate agreement with a video conferencing vendor. Each vendor should be evaluated on a case-by-case basis based on their policies, terms, and conditions, and whether they do access information on more than a random or infrequent basis. Until further guidance is provided, I recommend that to take the conservative view, which is to treat the vendor as a business associate and require that you enter into a business associate agreement with that video conferencing vendor. There's also patient privacy laws in Maine. They take a little bit more general stance on privacy. The current rule under Maine law is that a healthcare practitioner, facility, or statewide health information exchange must develop and implement policies, standards, and procedures to protect the confidentiality, security, and integrity of healthcare information to ensure that information is not negligently, inappropriately, or unlawfully disclosed. So it's very similar to the federal HIPAA law, where practitioners and providers and physicians must take steps to secure the medical information of their patients. And the final and fourth issue that I wanted to talk about is the corporate practice of medicine in Maine. Under Maine law, a licensed professional performing a professional service, which includes physicians, surgeons, PAs, nurses, and vets, if they want to form a corporation, they must incorporate as a professional corporation. The problem arises here is that any out-of-state professional who isn't licensed in Maine, or any non-licensed investor who is not permitted to be a shareholder in Maine. So in the case of telemedicine, where there might be outside investors who are interested in investing in a medical practice and giving them the capital they need to build out their business and provide telemedicine services, they wouldn't be able to be in the same corporation as a professional corporation. One potential solution that folks might want to look at is forming a Delaware entity and obtaining an authority to do business in Maine, which would allow a licensed professional to incorporate with other non-licensed professionals. So that's the end of my presentation. I'm going to turn it back over to Marie, who will take some questions from people in the audience.
Thank you so much, Dave and Dr. Loria. Very much appreciated. We do have several questions. I just want to, actually, Dave, can you quickly just reference the handouts that are attached? Those are from you, aren't they?
Yes. The first handout, which is the word-based handout, is the new proposed rules for telemedicine under the Maine Care Benefits Manual. So when I was talking about the new proposed rule that really opens the floodgates to be reimbursed under Maine Care for telemedicine services, if you're interested in learning more about that, I would take a look at the new proposed rules and see if that applies to your business or practice. And the second handout is just a telehealth article that discusses how states are starting to catch up to the telehealth industry and practice, and how the laws are trying to catch up with what people want to do with the new technology.
Okay, great, thank you. So I'll just dive right into the questions. So the first question pertains to your slide number 6, where you referenced travel or distance for Maine Care patients. So what if the services in the patient's community are considered subpar or have access issues? Could they then receive care via telemedicine from an outside community?
I'm just taking a look at that slide 6. Yeah, I think that might that would probably be permissible. So if the community wasn't able to provide that service, if there wasn't a physician in the area to provide that service, then it might be permissible. But again, that's under the discretion of DHHS, and they would have to make that determination.
Okay. And what I heard subpar, this is Michelle, as part of that question. You know, I think that's an interesting concept, subpar in the eyes of who? I know that there are some real aggressive marketing campaigns from people outside of Maine to be providing telemedicine services within our state. And I know they've actually said to me that they feel that we are subpar, therefore they're going to come into our referral areas. And so how would that work? I mean, if you already have services within a rural community, and then you have an outside group saying that they can provide a better service, is the establishment of quality in the eyes of the referring provider?
That's a good question. it's difficult to make that determination, and I think that's one reason why the current rule is really unworkable, because it provides a lot of discretion to DHHS to make these hardship determinations, which is probably one reason why in the new proposed rule they got rid of the hardship requirement and the prior approval requirement, because they didn't want to put themselves in the position to make that determination. As long as it's medically appropriate to provide the service over a telemedicine service, under the new rule, it's reimbursable.
So we've got about 5 minutes, and I do have a lot of questions. So this is a great, rich conversation, but I'm going to try to plow forward if I can. So the next question is, with regard to the proposed Maine Care rule, have any changes been announced pertaining to FQHCs who are the originating site? The rule appeared to be to specifically exclude FQHCs from receiving their encounter rate.
I'm going to have to take a closer look at the Maine Care Benefits Manual. It is probably discussed in the first of the 2 handouts in there. So I'm more than happy to take a closer look to answer your question. If you want to shoot me an email after the presentation, I'd be happy to talk to you about that.
Right, and if anybody wants, Dave had that information on his slide, but if you can't find it or didn't get it in time, I can get it to you, or again, this will be posted on our website, and you'll be able to access the archive and find it there as well. Michelle, can you tell us what percentage of EMH staff has been open to telemedicine, or if you had any pushback from providers? What's the kind of culture from the providers themselves in terms of adopting this?
You know, I think that in the past, like I'd say, and I'm new to EMHS, but I've done a lot of interviews and discussions with providers. I think in the past there was some spotty uptake in telemedicine, but more recently, I think it's been fairly consistent that providers are recognizing the benefits of telemedicine. And so we just did a survey of our practices, and there's a desire to both receive more telemedicine services and also to provide more telemedicine services.
Okay, let's see here. Is there an expected time frame for when the new proposed Maine Care rules may become effective?
I expected them to be effective by now, so it's hard for me to give you a time frame because it already passed my original expectation. I know that they did have a open comment period from the public, and that has since closed. So right now it's just going through the normal administrative procedures and the finalization process, and I check every day to see if it's been finalized. So I'm still optimistic that it'll happen any day now, but I don't have any guaranteed adoption date yet.
Okay, nothing firm yet. And regarding needing policies and procedures that address the patient's privacy rights, do these policies and procedures need to be separate from regular practice policies, meaning should they be specific to telemedicine?
No, I don't think that you need to adopt an entirely new practice and policies and procedures handbook to address telemedicine. I think that you can address telemedicine within your current policies and procedures. It may require a new policy regarding telemedicine. You might want to add some additional enhanced policies when using a telemedicine service. So it's important, next time you do your annual risk assessment for your practice to take into account whether you're using telemedicine services. And if you are, you might want to take some extra security measures to address that.
Okay, great, thank you. I think we can squeeze in one quick more question, and so I just want to alert everybody, you will be receiving a survey after the webinar, and we would greatly appreciate you filling that out to let us know what kind of feedback you may have on how we can improve or any ideas you have for future webinars. But one last question is, how does the current payment structure disincentivize telemedicine?
Well, I think I addressed one of the issues. So if you're providing tele-ICU services or a consultative model, you know, you can spend several hours providing consultative services trying to determine if a patient needs to come. Those are often the most complicated cases, and when they do come, you can't bill for any of that consultative time. I think other disincentivations are the barriers opposed that keep you from always being reimbursed for providing care within somebody's home. You know, the fact that you have to jump through so many hoops to get that approved, and it's not universally approved by insurers.
Sure.
I'm sure there's many more.
Okay. Well, thank you both so very much, and thank you to our attendees today. Again, reach out to me with any questions and check our website for the recording. I'll also send you a link to that archive so you can access it easily. Dr. Loria and Dave, thank you very, very much for sharing your expertise today. We really appreciate it.
Our pleasure.
Welcome.
Thank you.
All right. Good afternoon.